So today we're going to just go through kind of introductions, but if you are able to chat your name, we can forgo those. And then we have a really interesting presentation today by Dean Bricker, which I'll introduce to you in a second. We will go directly into our case discussions soon thereafterwards. Every single echo session that I've been involved in with the last 7 or 8 years has kind of run. It's always a little bit of a rush. I wonder sometimes if we should have an hour and a half, but nobody has an hour and a half because we all have to be somewhere at 8 or 9 or whatever on the hour. So we will try to do our best to stay on time, and I'll try to keep people on time as well. And after that, we'll have a wrap up. I will remind you once again to complete your surveys, which is extremely important. That's how we get feedback, and that's how we gauge the impact of echo as well. And that, of course, bodes very well for the future. And if there are any remaining questions, we'll address those at that time. Next slide. Okay, this is our introductory slide. These are our disclosures. Siran and Adam are here today, I believe. Dr. Bakris and Dr. Laffin are not with us this morning. Next slide. Okay, so I wanted to introduce Dr. Bricker, who is the Associate Program Director in Dayton, and has actually decided to tackle a very important and timely issue, that's shared decision-making and hypertension management. As a health services researcher, I can tell you it is a huge push from the Patient-Centered Outcomes Research Institute to make more decisions with the input and collaboration of patients. And it's something in my own practice I try to do, but I don't even know if I'm really doing it right. I just kind of read about it. So I'm very, very curious to hear, very enthusiastic to hear about Dean's talk this morning. So Rick, we can turn things over to Dean.
Good morning.
Good morning.
Can you hear me?
Yes.
Great. So I'm faculty at Wright State, and I work with residents and medical students. And one of my interests is to focus on teaching and practicing patient-centered care, especially by using motivational interviewing. And I'm bringing that up now because there's a lot of overlap between motivational interviewing style and some of the principles of shared decision-making. Next. I'm sorry, go back, please. The objectives for today to define what shared decision-making is, to describe a rational approach to how we can use it, and not only to discuss pharmacologic treatment, but also the non-pharmacologic treatment of hypertension with our patients. And then to describe some potential benefits of why we should even do this. Next. So what is clinical decision-making? So it's basically an approach, and it's a discussion that takes place between patients and clinicians where we share evidence and preferences. And there's 2 arms of this. If we just let things totally up to patients and say it's entirely in their lap, that's sort of abandoning patients. On the other hand, we need to make sure they understand and that they're supported to be able to express their preferences about treatments. Next. So why should we do this? First of all, it's an ethical imperative. Patients have a right to determine their own course in life, including their health care. And but shared decision-making has been around, described in the literature for a good while, since the early 1980s. And more recently, there's some Cochrane review a few years ago that summarized some 80 or 90 trials. And here are some of the benefits of using decision aids, which is a part of shared decision-making. So you can see that in summary, patients feel that they have better knowledge when we practice this way. They're more confident to make decisions, and they're more active in participating. But curiously, what the summary did not find necessarily is better efficacy or necessarily better adherence. So that's really what we hope for, but that isn't necessarily observed across the board. Next. So again, what is clinical decision making? Oftentimes as providers, we find it pretty easy to promote a specific treatment that we think might be the best one for a patient. But in reality, for a lot of medical problems, different diagnoses, there really are multiple treatments that can be effective, and there are many options. And so physicians, upon finding patient preferences, we may be willing to accept what we might consider less than our ideal treatment, provided that that it is an acceptable treatment and that the patient is going to have better adherence. Next. So what are some of the provider doubts? Not everybody necessarily accepts this at face value as something that we should be doing all the time. There's the perception that patients may not want to be involved in decisions. They may lack the ability to make decisions. They might make bad decisions, or there might be the pushback that might not be practical. There's time pressure in the office, or conversely, some of us may feel like, oh, I'm already doing this, but the reality is we're maybe not doing it as well as we should. Next. So I don't have time to go into a lot of these articles in depth, but I'd encourage you to, if you're interested in this, to look them up later. But this three-step model was described in the Journal General Internal Medicine, and suggests that we in the office should focus on several different types of conversations. So first, we should have choice talk with patients, which is we sort of explain to them we're at a crossroads. It's time to make a decision, and we've all been there. We've had patients where we've watched their blood pressure and it's sort of borderline and it's creeping up, and at some point we've decided that there's the diagnosis of hypertension is there, and we need to have a conversation about what to do about it. At this early stage, we should really defer closure, meaning if patients suggest to us early, like, okay, you're the doctor, you just decide for me, we should really defer that. We should say, I do have some ideas, but first I'd like to make sure you understand the options, and I'd like to hear what your preferences might be. So then we get into option talk, which is basically checking their understanding. So we can say things to the patient like, what have you seen or heard about how people can treat hypertension, or why you would want to treat hypertension? And so we should evoke what their understanding is, and hopefully list the options of what the possible treatments would be. And then along the way, some people have called this chunk and check, which basically is give them a chunk of information and then check their response to that. And then we can see what their understanding of harms and benefits is, and ask them to sort of summarize after we've together educated or discussed the options. And then finally, at some point, we do sort of need to ask them if they're ready to make a decision about treatment. Next. So in broad terms, what are the treatment options for hypertension? One option would be no treatment. And why would I even list that here? It's, I guess, obvious to doctors that that's not a great idea. But, in reality, if we suggest a treatment to a patient and they have poor adherence and don't make the changes that we've discussed, then in essence, that is no treatment. And And so really it is one of the options we should lay on the table. So no treatment, lifestyle changes, and then of course, medications are the basic choices. Next. And so decision aids are basically any brochure or DVD, online risk assessment tool, anything that we can share with a patient that would help them understand better is basically a decision aid. And so at some point, our discussion, if we're giving them the options or helping them understand options, would be at least some discussion about the major types of medications that we might consider for hypertension. And probably, we should be doing this, some discussion of the more common side effects. And although there's a lot of crossover, there are, we all know that there are some classes of meds that have more prevalent side effects than other ones do. Next. And then, of course, part of our discussion should include if a patient's trying to decide, do I want to take a medication or try lifestyle changes? A very important part of that decision making is, what impact is the treatment going to have? So we can expect, and there's probably lots of different numbers in the literature, but we could suggest to them that there may be a 30% risk reduction in cardiovascular events if we choose drug therapy. An important thing on patients' mind is, what about side effects? So side effects are pretty prevalent, 10% or greater. If they were to have a cardiovascular event, such as a stroke or a myocardial infarction, what is the risk of dying from that event? Probably a 30%. And then if they had an event, what is the likelihood that they would be symptomatic and have their lifestyle impacted by that? That's also probably 30%. And then a legitimate question would be, what is the risk reduction if they choose lifestyle changes? And that perhaps is 10 or 20%. Next. So I'm going to talk briefly about, what are decision aids? Decision aids are tools, basically, to help patients understand these discussions. And one of the leaders in this area is University of Ottawa. And, they have websites, and they're sort of a clearinghouse. They have a nice listing of a lot of different links for different diseases so they didn't necessarily develop all of these tools, but they've listed them here. And so if you go to their website and click on hypertension, there really aren't, you might expect there to be dozens of tools, but there really aren't. There's really only a couple that are listed there. Next slide. But they do have something that you might consider developing yourself, which is sort of a generic tool that you could apply to any diagnosis, where you could print this out and then you could go through these questions with your patient. What is the decision you face? What are the reasons that you should make this decision? What are all the options you should consider, etc. Next slide. So in this case, I would like to go, Rick, I'd like to go to the bottom one. Thank you. So this is one tool that I found to be pretty helpful, and just going to take us quickly through a hypothetical example here, and put in some values here. And I'm sure we're all sort of familiar with some of these risk calculators, such as the one we use for atherosclerotic risk. And this one's slightly different. So hopefully nobody will figure out that this one resembles me too much. But not all these numbers are exactly mine. Okay, so after you put in all the data, you can calculate a risk score. I may need to move this out of the way here. And so I think we're all sort of, vaguely familiar with tools like this, but basically plugging in these numbers, the computer program says that this person's risk, 10-year risk of a cardiovascular event is close to 10%, 9.9%. And then, of course, we know there's slightly different guidelines out there about blood pressure goal. But one of the nice things about this tool is if you go to the next page, see if I can get this out of the way, you'll see that there's a nice visual aid here for patients, so you can explain to them that what this calculator means is that for 100 people, 10 people would potentially have a heart attack or stroke in the next 10 years. And one of the nice things about this is we can go over here and we could click on various options and see what the impact is on the blood pressure and also on the 10-year risk. So let's say we were going to do all of these lifestyle changes. We can see how that changed the risk profile over here. And so basically, out of those initial 10 patients that might have an event, 2 have been saved an event. And so, I guess there's a couple of ways patients might look at this. They might say, wow, that's a lot of effort to just save 2 people. But, of course, we all think that is worth it. And then, if you're into evidence-based medicine and want to try to explain this, number needed to treat, basically means 47 people have to do these changes in order to impact 2. But it's probably worth it. And then we can also plug in over here what would happen if we start medications. And we can see that risk is reduced even further. So this is a pretty nice tool in that you can go back and forth and sort of toggle back and forth and demonstrate how these factors affect risk. And then another nice feature here too is if you click on this chart note, you could potentially import or copy and paste this nice little assessment into your note for the day that says, on a given day, you had a nice shared decision-making discussion and what choice you made together, you and your patient. Next slide. I need to exit out of here. There are challenges in implementing this, especially in older populations, because we're used to guidelines that focus on one disease process, but yet most of our older patients have got 3 or more chronic diseases, which means they're on a lot of medications, and they have a very heavy burden of treatment. And so one of our jobs is to set priorities for patients and help them understand priorities. Because if we just focus on one illness, that may not be appropriate. So for instance, should a patient with late stage cancer, do they necessarily need to continue a statin medication? Or for instance, are beta blockers mandatory in a patient who's depressed who had a MI? So these are challenging considerations, and we definitely need to find out what patients' preferences are. Next. So this is a more recent systematic review that tried to look at if we're going to practice shared decision-making for hypertension, what should we emphasize? Should it be training healthcare professionals to do this better? Should we put our emphasis on decision aids, patient coaching, or various education tools? Unfortunately, there really is, hard to demonstrate that this really impacts people's blood pressure. But of course, we hope that it increases their adherence and their participation in their care. Next slide. And we're sort of getting low on time, so I'm not going to go into great detail on some of these slides. This is just an example of a decision tree, which I think is probably unnecessary for many of our patients. A lot of our patients may have, perhaps poor healthcare literacy, and they may have poor numeracy. A lot of doctors, self-included, have poor numeracy. If we're trying to go through a mathematical model, that may be beyond what we can communicate easily in the office. Next. And unfortunately, I think I'm sort of out of my time, but I do want to put in a plug for motivational interviewing. So I think a lot of practitioners certainly have heard about motivational interviewing, but I would say that it's really challenging to practice this well in your practice. But I think it's extremely important. It's a style of interacting with patients in a conversational style where we really emphasize open-ended questions, reflective listening to demonstrate that we understand what's important for the patient. But at the end of the day, it's trying to guide the patient to do the things that are their work. And what is the patient's work? The patient's work is the hard work of lifestyle changes. So we can suggest that, but really challenging for them to do it. And same thing for medications. We can say, oh, take this medicine, but it's the patient's work, if you will, to actually adhere to that medication. So the more we can understand this style of interacting with patients, probably the better we're going to have better rapport, and probably adherence is going to be better. And at the end of the day, I submit that doctors feel better about this too, because if together we decide that lifestyle changes are necessary and great success hasn't been achieved, it's not necessarily my fault, not necessarily the patient's fault, but together we're striving for better health. I think we could skip to the end. There are more slides about motivational interviewing, but basically, this motivational interviewing can be applied to shared decision making. They fit together very well. We'll just skip ahead to slide 29, if you would, please. Thank you.
Nice job. I want to paraphrase a couple of questions that have come through. One deals with the discussion around side effects, and it's exactly the thing I was wondering about as well, especially with respect to hypertension. How do you place that in the overall context of shared decision making? And can this be overplayed is the language in the question. I mean, if you mention a lot of side effects, patients may be ambivalent about seeking any specific treatment. So what are your thoughts about that?
I take it you're directing the question to me.
Yes.
Yes. Um, I think it's something we should ask patients up front, but some of them volunteer more commonly than others. Whenever I'm wanting to start a medication, I ask patients how, perhaps we should consider medication. What are your thoughts about that? I try to make it an open-ended question. And so commonly, if side effects is a big concern of theirs, they will voice that up front if you allow them by asking an open-ended question. I think you get less information to say something like, are you worried about side effects? Because then you get a closed answer and it may or may not uncover something. But anyway, and then of course, probably the side effects of lifestyle changes are not, they aren't as great. But again, at the end of the day, if your patient is very concerned about erectile dysfunction and you don't address that and you aren't aware of that and you start a beta blocker, they may not be taking the med and you may never know it. And so you see them back, they have uncontrolled hypertension and they're unwilling to share it or afraid to share it. You haven't explored it and you pile on another medicine and you haven't achieved your goal.
Okay. And the final question, I think, comes from Dr. Boland, and that is the one thing I've always wondered about as well. Some of these discussions are extremely meaningful, and I think you can make a strong case, which you did. They do promote adherence, consistent with how we ought to deliver care. But is there a way to structure visits so that you have more time with patients to have discussions like these? Do you have any tips about using time for shared decision making when time is scarce?
Sure. I think you could let patients chew on things for a while at home and schedule a visit and devote the whole visit to what you're going to do about their hypertension. And so letting them think through things on their own at home or giving them a link or something that, whatever style they prefer to digest information, but schedule a visit to specifically address this.
Okay. Terrific. Thank you so much. I just make a couple of comments about risk communications because that's another hot button issue. I used to have an appointment at the RAND Corporation and it seemed like that's all they ever discussed or researched over there, the RAND Health Division anyway. But so numeracy is a huge challenge among our patients. The age-old observation that 2/3 of people, if told that a bus is arriving at a certain time and knew what time it was now, cannot tell you how many minutes they have to wait for the bus. So not surprisingly, a lot of them are late for their appointments. So in terms of risk communication, Dean had mentioned, the decision analysis tree is not going to be easy to understand for most of our patients. A number needed to treat is hard to understand too. But what's been shown is they do understand percentage risk reduction. So you have a 30% less chance or whatever. And that, of course, is used a lot by pharmaceutical companies when they advertise to patients. Once again, we're going to have our cardio conference on May 17th. Please register if you have not already done so. The keynote speaker is the Princess Brewer from Mayo Clinic on inspiring and empowering communities to improve cardiovascular health. In addition to that, I wanted to announce you will have your routine feedback opportunity. After this, you will get a post-clinic survey. Always, traditionally an echo session is more of a wrap-up and an opportunity to tie up some loose ends. Now, we'd like to do that systematically because if you just say, hey, do you have any questions? And I throw it out the group, we're going to have a very short session. So you're going to get a survey in your email very shortly that asks you to identify 1 or 2 issues that you would like to address. So do you believe that we did not address fully in the sessions that we've had so far? The reason that's important is that over time, as we roll this out, those issues can become part of the primary curriculum as well. If it's just one little thing and we already covered it and somebody missed that session or just wasn't aware of our discussion around it, that's one thing. But if the same issue comes up over and over again, it becomes a core part of the curriculum. As an example, the pediatric cardiovascular risk curriculum that I ran for many years, I deliberately avoided the issue of management of obstructive sleep apnea because there wasn't, besides tonsillectomy, there wasn't a whole lot to talk about, but people sure wanted to talk about it and its impact on blood pressure and all sorts of things. So that became part of the curriculum, and that's what we're looking for. So please do submit things. As another example, I think I would like to know a little bit more about objective measures of adherence with antihypertensive drugs and how we can actually measure perhaps based on tools and questionnaires, how people are doing with adherence. So that might be something I'm interested in. Apart from that, we will see you next week at May 2nd, and that will be our final session in this pilot series. I hope it's been enjoyable to date so far, and give us some feedback. Thanks, everyone.
Thank you.